This will be a sort of a brief introductory talk where I will just go over, I guess, what we understand about what blood clots are and why they happen, and it might serve as a bit of a lead into some of the other more specific talks that will follow later this morning. So I guess, So I guess some of you will already be, I suppose, familiar with the principles of what our blood does and how it circulates. So each adult has about 5 litres or about 10 pints of blood that is constantly being pumped around all our blood vessels at very high pressure. And the main functions of our blood are obviously to deliver oxygen and nutrients to our tissues and organs, but it also serves an important role in our immunity and also in eliminating waste products that are generated by our organs. But in order for our blood to be able to fulfill all these roles, it needs to be able to flow under high pressure in liquid form, completely unimpeded throughout all our arteries and veins. And the problem with that, I suppose, is that if our blood is continually circulating rapidly under high pressure in liquid form throughout our body, and if we injure ourselves or accidentally cut ourselves, in theory we could rapidly lose all of our blood volume through bleeding. So for that reason, we need to be able to rapidly seal off any breaches in our blood vessels in order to stop inappropriate loss of blood or bleeding. And if we couldn't do that, then even potentially minor injuries would be potentially life-threatening. And so humans have evolved with a blood coagulation system which allows us to keep blood flowing under normal circumstances in this liquid state, whilst also being able to rapidly form a clot in the setting of any form of injury. And it's when this system becomes dysregulated that we can develop problems with either clotting disorders or even bleeding disorders. So the blood clotting system, or the blood coagulation system, consists of tiny blood cells called platelets, as well as numerous circulating substances called clotting factors, which circulate in the blood. And some of these clotting factors act by driving blood clot formation, and some of them act by suppressing or inhibiting blood clot formation. But these factors all work together in a very tightly regulated and tightly balanced way to maintain our blood flowing unobstructed under normal circumstances, whilst also allowing us to be able to rapidly form a blood clot in the setting of injury if that's required. And so the only healthy trigger for clotting activation actually is blood vessel injury. So in that setting, we get activation of blood clotting just at the site of the injury, leading to the formation of a very small amount of clot that is just big enough to seal the hole in the blood vessel. So, and the natural sort of anti-clotting factors in our blood help to make sure that the clot doesn't get any bigger or any bigger than it needs to be. And so in this way, normal blood flow can be maintained throughout the blood vessel, but at the same time, inappropriate blood loss or bleeding through the hole in the blood vessel is prevented. But in contrast to this, harmful blood clots occur when there is excessive activation of the clotting system and when our natural anti-clotting factors aren't able to turn it off. So in these cases, large clots are formed within the blood vessel, and these continue to grow until the point comes where they start to block the blood vessel, and this causes pressure or I suppose a backflow of pressure, which leads to the symptoms of thrombosis like the pain and swelling that we get with deep vein thrombosis in the lower limbs. As well as blocking the veins and causing pain and pressure, these clots can also break off and travel in the circulation, usually lodging in the lungs, causing pulmonary embolism or PE. And so DVT and PE together are known as venous thromboembolism or VTE. So these are blood clots formed inappropriately in our veins, which have the potential to block our veins, causing problems, and also to travel to other organs, primarily the lung, where it can also obviously block blood vessels there and impede our ability to have normal respiratory and cardiac function. So how common are blood clots? So unfortunately, venous thrombosis is actually really common and much more common than I think people understand. So the annual incidence in Ireland of blood clots are about 1 in 1,000 adults, but in fact it's estimated that for all of us, our lifetime risk of experiencing some form of venous thrombosis is about 1 in 12, which is obviously a lot more than I think people might recognise. But the big question then, of course, is like, why does this happen? So we have a blood coagulation system, obviously, to prevent inappropriate bleeding, but why does this sometimes become dysregulated, leading to blood clot formation? And so, as I said earlier, the blood is maintained in this liquid form, circulating under high pressure by a very highly regulated, tightly balanced system mediated by our blood clotting cells and our blood clotting factors. And abnormal or harmful blood clots occur when we lose control of this tight balance. And this is, in a way, this is kind of a simplistic way of describing the problem, but because in truth, like the various biochemical reactions which govern the activity of our clotting system is highly complex, and any disruption in any of these reactions could potentially lead to either abnormal clotting or abnormal bleeding. But ultimately it does come down to this idea of the lack of balance within our own natural blood clotting system in our blood. There are some scenarios, I think, which are good examples of this imbalance in action. So major surgery is one of the strongest drivers of abnormal clotting and of blood clotting risk. And for this reason, the vast majority of people who are undergoing major surgery will receive some form of short courses of anticoagulant treatment around the time of their operation in order to suppress the clotting risk. That's usually in the form of those little injections like Clexane or Inheb that we get at the time of surgeries. And when we think about what surgery involves, it really shouldn't be that much of a surprise to see why blood clots are so common in that setting. Because as I said earlier, the main trigger for activation of blood clotting is blood vessel injury or tissue injury. And when you think about it, surgery by definition is a form of injury because it requires that the surgeon is coming at you with a scalpel and making lots of incisions. And so the more extensive the surgery is, the more tissue injury you have and the more potential you have for clotting activation. And in some cases, and for reasons that aren't necessarily clear, the clotting response in certain people will become too excessive and lead to a blood clot being formed. And the risk of clotting around the time of surgery can also be increased by things like inflammation or infection, which can drive clotting, which are common as well at times of surgery, and also by immobility, and particularly in the recovery phase, because if we're not moving after surgery and blood is able to pool in our lower limbs, that can be a risk factor for thrombosis as well. Another well-described risk factor for thrombosis is pregnancy. So during pregnancy, there are lots of hormonal changes which appear to drive changes in the levels of some of our clotting factors. So some of our clotting factors like fibrinogen and factor VIII increase massively during pregnancy. And this hormonal effect is actually thought to represent a sort of evolutionary effect, which occurs due to the fact that for centuries, the biggest risk to life for a pregnant woman was the risk of major bleeding at the time of labour and delivery. And so humans have evolved over centuries and over thousands of years to have enhanced clotting power during pregnancy in order to reduce that risk of bleeding. But unfortunately, in modern times, that means that there will also be some women who unfortunately will experience blood clots during pregnancy. There are some other reasons that blood clots happen during pregnancy, including due to the effect of the enlarging womb compressing on the pelvic veins, and also, of course, the trauma and tissue injury which occurs around the time of labour and delivery. So in all of these types of scenarios, it's usually a combination of external factors interacting with the person's own individual level of risk. And again, cancer and cancer therapy is another very well recognised risk factor for thrombosis. So some cancer cells will actually directly release substances into the blood that will cause clotting, harmful clotting. As well as that, there are certain chemotherapy drugs which will directly activate clotting. And as well, many patients with cancer will require some form of surgery or invasive procedures, which again, by the effect of this tissue injury, will potentially increase the risk of clotting, interacting with the effect of their tumour cells and their therapy. So among the population of people with cancer, the risk of thrombosis is incredibly high, and this is one of the biggest areas of risk or of need, I suppose, in our practice. And of course, there are multiple other considerations or multiple other scenarios associated with thrombosis risk, including lower limb injuries, hormonal contraceptives, and certain infections such as COVID-19. But it's also worth, I suppose, remembering that about 30 to 40% of blood clots occur in the absence of any identifiable external trigger, and these are called unprovoked or spontaneous blood clots. And these clots happen because for all of us, every single one of us has a certain level of inbuilt individual risk for blood clots, just like we do for getting high blood pressure or diabetes or asthma or any other condition. Blood clots aren't just caused by external figures. There is a certain amount of inherent personal risk that we are all born with, and that's related to our genetic makeup. And we should really think about venous thrombosis in the same way that we think about other kind of cardiovascular diseases like stroke or heart attack. So in both these conditions, there are some external modifiable risk factors like high blood pressure or high cholesterol that can lead to an increased risk of stroke or heart attack. But there's also a certain amount of just inbuilt individual risk, and sometimes you hear people saying, "Well, heart attacks run in my family, and no matter no matter what I do, I'm at risk." And that's why sometimes young, fit, healthy people will develop blood clots for no reason, and that's due to a sort of being born with a certain amount of imbalance in your clotting system, where your pro-clotting forces are just a little bit stronger than they should be. And this often leads to questions about, screening for genetic problems, or what we call inherited thrombophilia, which are the conditions that we're able to test for that run in families and which are associated with an increased risk of thrombosis. But unfortunately, although there is definitely a very clear inherited component in many cases of blood clots, current scientific techniques have only been able to identify a very small number of the responsible genes, such as factor V Leiden, which some of you may have heard of. And in most of these cases, including factor V Leiden, the overall effect on clotting risk is probably quite modest. So testing for thrombophilia using current techniques is a fairly limited value in most occasions, and can actually give almost false reassurance, because a negative screen can only detect, I suppose, the amount of risk represented by the smaller circle here. So it does not mean that a negative screen does not mean you don't have a genetic component to your clotting risk, because we're not able to actually measure the entirety of the genetic contribution to risk of thrombosis, even in the most advanced labs. And all these things, I suppose, are important factors when we're thinking about treatment options, and particularly duration treatment. So I'm sure everyone, of course, he will know that we treat blood clots with antithrombotic therapies like warfarin or DOACs. But the big question for many of us is, how long do we treat someone for? And it does sometimes feel like, trying to look into a crystal ball, because it can be hard to make that call. And the primary thing we use to make that call is looking at the circumstances of the blood clot. Because if you get a blood clot that's provoked by a very clear major provoking factor, then once that factor has resolved, you're probably okay to stop anticoagulation, because the risks of the treatment might outweigh the benefits. But for people who get unprovoked clots, or clots that occur in the setting of very minor risk factors, we sometimes worry that actually that's a sign that this person also probably has some degree of predisposition inbuilt into their cells. And in those scenarios, we tend to recommend more long-term treatment, particularly for people who have recurrent unprovoked blood clots. But all of these decisions have to take into account, of course, the risk of recurrence, but also the risk of bleeding, and of course the preference of the individual person themselves as well. So I'm going to leave it there now, but I'm happy to take any questions. Thank you.
Visit thrombosis.ie. Spot the signs, save a life.